Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron, and I'm joined today by two specialists from MedStar Georgetown Cancer Institute, Dr. Keith Kowalczyk, a renowned urologic oncologist at MedStar Georgetown University Hospital, and Dr. Luther Ampey, a leading radiation oncologist at MedStar Montgomery Medical Center. Did you know that 1 in 8 men in the US will be diagnosed with prostate cancer during their lifetime? The good news is that 98% of prostate cancer patients who get treatment live for at least 5 years after treatment. Today, we'll discuss available treatment options for prostate cancer and debunk cancer treatment myths. So, if you're watching, thank you so much for joining us. Give us a like to let us know you're watching and share this broadcast with your friends and family to help us spread the word. Before we get into the questions, let's learn more about our experts. Dr. Keith Kowalczyk, urologic oncologist, could you start for us?
Absolutely. Like you said, my name is Keith Kowalczyk. So I'm a urologic oncologist, mostly focusing on prostate cancer these days. I'm the chair of urology at MedStar Georgetown University Hospital and also the physician executive director for MedStar Health Urology Service Line, as well as the robotic surgery service line. So that's where I am, and it's a pleasure to be here again with my good friend, Dr. Ampey.
Thank you so much. And Dr. Ampey, would you introduce yourself?
I'm Luther Ampey. I'm a radiation oncologist, and I'm also the medical director of the oncology service line at MedStar Montgomery Medical Center. I've been here for now over 20 years, which I can't believe. It's a pleasure to be here with my good friend Keith as well.
Thank you so much for joining us. Let's get into some questions. What does it mean to be diagnosed with prostate cancer?
I think the number one thing to take home is that survival for prostate cancer is excellent, really almost across all stages. Higher stages might need more treatment, but you hear the C word, and that is scary for patients to hear that they have cancer, and I completely understand that. But it is very, very treatable. So the number one thing is don't shut down. This is something that we can help you get through, and sometimes you may not even need any aggressive treatment. So what does it mean to be diagnosed for prostate cancer? Well, hopefully these days we get it diagnosed early and are able to treat you, cure you with minimal side effects. That's what I would say is don't panic, be concerned, but we're here to help.
How common is prostate cancer?
I believe, Amy, when you opened, you mentioned the number 300,000. So in 2024, we're actually estimating that to be approximately the number. That means about 1 out of 8 men in their lifetime will get diagnosed with prostate cancer. And if I sort of break that down a little bit more, if we look at it by age, under the age of 50, it's about 1 in 350. Between 50 and 59, it's about 1 in 50. And above the age of 60, it's about 60 out of 100. So you can see by those numbers that prostate cancer tends to be a disease of older men, the average age being about 65 to 67. And therefore, the prevalence increases as we get older. So if we go looking for prostate cancer, which we oftentimes do with screening programs, we might start with baseline screening between 40, 49. We might do regular screening between 50 and up. Therefore, we're going to likely find disease if it's there, and it does happen to be more common in men that are older. Now, one of the things I would like to point out in terms of prostate cancer is that of all cancers that are diagnosed in the United States, prostate cancer will account for about 15% of those. And of those patients who die of cancer in a given year, prostate cancer accounts for about 5 to 6%. The prevalence of prostate cancer is significantly higher in men of African American descent, or ethnicity rather. And that's even worldwide. When you look at it, all comers worldwide, African American men in the United States have the highest prevalence. They also have the highest mortality. So that's an area that we really want to pay attention to when we talk about screening, because of the prevalence and the effect on quality of life and survival in that group of patients.
What are the risk factors for prostate cancer?
Yeah, Luther set me up really well here for the number one thing, which is African American ethnicity or descent is huge. So it goes from a 1 in 8 total, taking all people. If you consider men of African American descent, it's about 1 in 6 that will be diagnosed in their lifetime. And as Luther said, higher risk of being diagnosed at higher stages, higher risk of being diagnosed, with higher, like just more aggressive cancers. So therefore, higher risks of death. I think this is very multifactorial. But the point here is that is one of the number one risk factors. So when we talk about PSA, there's a lot of controversy around PSA. I don't think there should be necessarily controversy, it just needs to be, it does need to be handled reasonably. And not everybody needs a PSA every year, but African American men do PSA they need to be screened. Other men are family history. So when we say family history, sure, you could have a distant grandfather, uncle, but what really puts you at high risk is if someone in your household, so father or brother, has had prostate cancer, you're 2 to 3 times increased risk of having that. A lot of genetics go into play there. And then finally, not new, but definitely newer, is patients in BRCA families. So normally this is associated with ovarian and breast cancers in their families. Well, if there's a very strong history of ovarian breast cancers in patients, their female family members, they may have BRCA, and those patients have about an 80% lifetime risk of developing prostate cancer. Thankfully, stage for stage, hopefully even in African American men, if we find these at the right time, they should be equally curable. The trick is finding them at the right time without also diagnosing men that don't have these risk factors that probably don't need to be screened every year. So those three, African American, family history, BRCA history, and will probably be more that will come out in the future, they should be screened every year. Everyone else, talk to your doctor about it, maybe intermittent screening, and that's the way that we avoid overdiagnosis on cancers.
Is there an minimum age that they start screening PSA?
It's hard to say. So we, as Uther alluded to, baseline PSAs are big for us right now. That means in your 40s, 50s. So at least get one baseline PSA, because there are men without risk factors that I just talked about that will suddenly in their 40s present out of nowhere with a high risk prostate cancer. If you got one PSA, you could tell. So men with a baseline PSA above the mean, that it's all changing, but say above 1.2, 1.5. That's above normal for someone in their 40s. And that's not someone that we would say would need a biopsy or treatment, but that's someone we would watch much, much closer. So that's a discussion. If you have risk factors, start at 40. Some say 45, I would say 40. If you otherwise between 50 and 55, that's when men without risk factors, you should get a baseline in their 40s, and then at 50 to 55, consider doing that more frequently.
Okay.
Dr. Kowalczyk, you brought up the PSA number, and a lot of people generally know that 0 to 4 is considered to be the normal range. As a person who diagnoses prostate cancer, what is your feeling about the number as it relates to people that have higher risk, like say African American males? What should be the scale for them? Is it still going to be 0 to 4?
No, I mean, that 0 to 4 range is there because I think we all want to see what the normal range is. And I often tell people, and it's a common question, what is a normal PSA? Well, I think anyone that has above 4, sure, that is abnormal, but some people that might just be your baseline PSA because of other reasons that are not prostate cancer. So what's more important, if you're younger and your PSA is 3.5, that's really high, younger by 40 years old. If you're 80 years old and your PSA is 3.5, I have no problem with that. So age comes into effect. PSA definitely gets higher as you get older normally. But the trend is the general trend line that we're looking for. And we can do other biomarkers and tests afterwards to kind of get down into the thick of things to see if a biopsy or not is needed. But the trend of the PSA is the most important thing. Now, there are some PSAs out there over 20, over 30. That's no good. Those are the ones that, or even over 10, that we have to really dive down into.
We did have a question come in from our audience. You mentioned biopsy, and Chris asked, can you discuss the various biopsy procedures? I have heard there are newer, less painful procedures.
I think a biopsy, no matter what, is never going to be pain-free. So I'll say that, but we do our best to keep them comfortable. Probably what Chris is alluding to is there's transrectal biopsy versus transperineal prostate biopsy. And I'm involved in a big randomized controlled trial for both. And actually the transperineal, that avoids needles going through the rectum. So there's almost zero risk of infection, and you don't need to take any antibiotics for prophylaxis. So that's good for general population health, is if we're using less antibiotics, that's good. Transrectal, there is still a risk of infection, which can be severe, and you do have to take antibiotics for that. But The transperineal is probably a little bit more painful, but it is newer in terms of less risk of infection. Transrectal is less painful, but more risk of infection. So there's trade-offs. I don't think one is clearly better than the other than you don't need any antibiotics to eliminate infectious risk. But we've gotten very good at mitigating decreased infections. That's been seen from our studies so far, the PREVENT trial, where we still had a difference in infection rates, but it was very, very small. It was very small. So those are the two main ones. We don't, if people have metastatic disease or they have a lesion in their bone that went from their prostate, that's a different story altogether. And we might do a biopsy of that instead of the prostate. But if we're talking routine prostate biopsies, those are.
Thank you. And then we also had a question come in from Tom asking if you could comment on PSA versus PSE.
PSE?
PSE?
HI?
I'm not sure. I will confirm.
Oh, no, I'm not clear what PSE
Okay.
is. But there's frequently, new tests that are coming out that are not quite ready for prime time that we would call biomarkers. So PSA is still the first number one prime time frontline test that we would always use.
Okay, thank you. Let's get back into our questions. What are the treatment options available for early stage prostate cancer?
I've been talking a lot, so I'll let Luther take over.
So from a radiation perspective, there are a number of treatments. So I generally like to start out by saying that there are treatments that are what we call internal. So those are treatments where we actually literally insert the radiation source into the prostate. And then there are treatments that are external, where a patient will lie on a table and be treated from outside the body with the radiation being aimed at the prostate. So of the ones that are internal, they can be permanent. Those are seed implants, which are most commonly known in the lay public. Then there are also ones that are temporary, where we put catheters into the prostate. We run a radioactive wire into the catheter, dwell it there for a period of time, usually minutes, and then remove it. Those are the two internal types. Usually those are, especially the seed implant, is more appropriate for patients who have lower risk disease. We will sometimes do implants in other patients, but we might couple it with external beam radiation. The choice that we make is predicated on an extensive discussion that we have with the patient, looking at what the options are and what would be medically indicated or not. In terms of external beam, there are a number of treatments that can be done, and we look at them now in terms of length of overall treatment time. So we will have patients who will be treated in what we call a moderately hypofractionated way. Usually that would be treatments up to about 5.5 weeks of treatment done Monday through Friday. So let's say a number of 28 or 25. There can also be treatments that can be done with a little bit higher dose per treatment. Those are called ultra hypofractionated, and they can be done by stereotactic means, meaning we can treat those patients in 5 treatments. So at Georgetown, we actually have what's called the CyberKnife, and I think people might be familiar with that if they know external beam. The CyberKnife is actually not a surgical instrument. It's actually a radiation instrument, but it was called knife because it's a little bit more precise in terms of how it's aimed. So it's got knife-like precision. That's why it was named that. But that is under the umbrella of stereotactic treatment, and patients who get that treatment will be treated in 5 treatments. So in radiation terms, our treatment options run from internal to external. And then the third thing that I'll throw in there is hormones. So some patients may be familiar with that term. Hormones is a way of doing chemical castration, lowering the testosterone level in the patient to castrate levels, because we know that some prostate cancer cells will respond to those, malignant cells will respond to the withdrawal of testosterone, which will cause them to go into a state of what we call apoptosis or cell death. So when we couple that hormones with external radiation, that's typically utilized in patients who have a little bit more high-risk disease. It's still localized, but more high risk, meaning potentially more aggressive, potentially having the opportunity to get outside the prostate in a sooner fashion. So I think that kind of summarizes the options. But again, I just want to throw out there that the option for treatment, there are many. They have generally similar efficacy. The side effect profile might be slightly different, and we can get to that, I'm sure, in a moment. But the discussion is really predicated on the individual patient preferences, and we look at all that and sort of coming to a decision.
Yeah, and I would echo, there's not one magic bullet for most people. I can say, in general terms, we tend to treat younger patients, less than 60, with surgery, which I'll get into later, radiation, a little bit older, but those lines are blurring because we're just the technology we have with surgery and radiation we're just getting much better, where we can just provide more options for patients. I just wanted to go back to the PSE test. Actually, I remember that's a test that was actually just approved in I believe September. So it's quite new from England. And that's what I would consider as a secondary test, so similar to what's called the 4K score or prostate health index or exosome DX. If you have a high PSA, and you're looking to not do a biopsy, these are what we call sensitive tests that if those are negative, then we can confidently say you might not be a biopsy. So a PSA is like that, but it's a secondary test of PSA. It does not, if we got everyone one of those tests, it would be not great. That's like a secondary test that we might get down the line. And there's still no clear winner there. In my opinion, MRI is better than all of those right now. So I just wanted to
that's great.
to that. As now so I'm the surgeon and Dr. Ampey's the radiation oncologist. What I do like to say is that we're in this to get you the best possible treatment. I'm not going to be there rooting for you to get surgery or radiation. I may have a preference and I may try to give that to you. But we want what's best for you. So as a surgeon, I do robotic prostatectomies. It's pretty much all I do now. Thousands of them. And it is your number one answer for, it's quick, it's done. We send people home the same day now that we do it robotically. And they have a catheter in their bladder for about a week. A lot of patients get back to work within a month. And that's the most comprehensive thing you can do because I'm removing all of the prostate. So we get full pathology. We know exactly where the tumor is and things like that. But as Luther said, in terms of overall survival, it's not any better than radiation. You're going to live from prostate cancer no matter what you get. What you have to look is from downstream is what is your chance of this cancer coming back? And that can happen with prostate cancer as it can any other cancer. And how are you going to treat that if it happens? So I think that's why we tend to do surgery on younger guys, because if they have 20, 30 years left, that cancer can come back at some point, and Luther can save me by doing radiation after surgery. Versus if somebody gets radiation at a very young age, I can still remove that prostate, but the side effect profile is not great. So, and we can get into the side effects as well. But yeah, robotics came about 24 years ago because of the prostate. It's expanded so much, but it truly has become a game changer, I would say, over the last 5 to 10 years in making this surgery much more appealing to a broader audience of people.
That's great. Mike?
Dr. Kowalczyk, one of the things that you said that I oftentimes mention to some of my patients when we talk about surgery versus radiation, and they might be a younger patient. And so obviously I said earlier that prostate cancer tends to be a disease of older men. So as we see younger men getting prostate cancer, we know that there's some kind of biological issue that we don't necessarily know what it is, but we know that, hey, younger men shouldn't be getting prostate cancer. So one of the things that I think that was key that you said was that when patients are biopsied, we're basically sampling the prostate. So we're getting kind of an idea of how much cancer or what type someone has. But when you actually remove the prostate, you do get much more information. You know how large it is, better sampling can be done. We can take a better look at it. And so as treatments are evolving and we have potentially other ways of treating prostate cancer that might be burgeoning or on the horizon, I think understanding the biology and having more tissue from younger men is potentially another advantage that surgery might have in that particular cohort of patients.
Yeah, 100% agree. I mean, sometimes you'll go in and get a surprise. The Gleason score and the amount of cancer that you thought you were operating on tends to be a lot more. And then you have to escalate treatment after that. And not only is it surgery, but maybe earlier, kind of a lower threshold for doing radiation and hormone therapy in addition.
Thank you.
And we can talk about focal therapy too. I know that's on the list. So unless you think we need to move on.
No, that's okay. We actually had a question from the audience about that.
Okay.
So if you could definitely cover that.
Yeah. So focal therapy it's been around for a long period of time. Is high intensity focused ultrasound cryoablation. So that's either burning prostate tissue or freezing prostate tissue. And then there's laser as well called TULSA. They all are aiming to do the same thing, which is, kind of you compare it to breast cancer, the partial mastectomy, like the partial prostatectomy, which surgically some people do, but it's not recommended. recommended. So we're trying to treat one area of the prostate while leaving the rest behind at normal, hopefully, and that decreases the side effects. Now, what's new is that over the last 5 to 10 years is the ability to deliver these technologies has become much better. We used to have to just freeze or fry the entire prostate, and not only would it not kill the cancer, the side effects would be just as bad, if not worse, than our treatment. So focal therapy is burgeoning. I would still say that it's definitely not standard of care, but in some patients with an intermediate risk disease, I would not do it for high risk. I would not do it for low risk, which should have active surveillance. Intermediate risk disease, you can see it on MRI. It's in one spot. The prostate's not too big. You can do focal therapy, with the caveat being there is a 30 to 40% risk of recurrence with our current literature. But it is something that can maybe for 5, 6 years kick the can down the road a little bit until you might need radiation or surgery. But so there's still a lot of questions to be answered. I'm very happy that we do have a lot of great academic urologists that are looking into this. It was big in the community without much research being done on it, and now I think there's a lot of great research being done on it. So there's definitely an appetite there. We do offer it right now. We have done it at Georgetown. We're building a program primarily at Washington Hospital Center that will expand. But again, we're only going to do that for you if we think it's the right treatment. Not here to treat everyone with, it's not a gimmick, but if you're not a good candidate, we're going to tell you.
Right. Thank you. Yeah, Angelo in our audience had asked to elaborate on focal therapies like Tulsa Pro, which I think you mentioned,
Pulses laser, yeah.
Nano
Yeah.
Knife.
And they all have their different positives. And, if you have a focal therapy program, you really need all of them because they treat different parts of the prostate a little bit better. So it's pretty complex. I do think that focal therapy, though, every year is becoming more popular and for good reason. People don't want to have side effects. And I think we're getting better at it. But at the same time, it is not as sure of a thing as curing cancer as radiation or surgery. It just is not.
Okay. We did have another question from our audience from Mike who asks, what about metabolic therapy, starving the cancer cell from glucose and glutamine?
Yeah, I mean, that kind of comes in. There's lots of information out there on diets, and Luther, you can jump in here if you want. I've heard that, low glucose diets, low carbs, things like that. We don't have one magic bullet that we can say attacks prostate cancer. It's impossible to say that those diets will affect one cancer or the other cancer. What I always tell everyone is a good diet that's good for your heart is good for your prostate. I'm not against any of this stuff as long as it's not harmful to you and not costing you a lot of money. There's really not much data out there outside of plant-based diets and Mediterranean diets that show that decreases general cancer risks, not prostate cancer risks. And I'm sure if Luther has anything to add there.
Totally agree, Kate.
Before we move on, Dr. Ampey mentioned hormones, and Lynn in the audience asked, what determines if hormone shots can be a total of 3 or 4?
So I'll go ahead and take that question. So when we use hormones in combination with radiation, we typically will use them for risk groups that are unfavorable intermediate risk through very high risk. And so the idea behind that is if we go back and look at the history of the development of hormones with radiation, some of the initial clinical trials that were done in the late 80s demonstrated that when you starve cancer cells of testosterone, you can actually get some of them to die off. And if we have a lower volume of cancer cells that are available when we treat with radiation, we get better efficacy. So comparing radiation therapy alone to hormones plus radiation, the combination does better in certain cohorts of patients. So the determination as to how long a patient will stay on hormone therapy has been worked out in many other trials. So in patients who have an unfavorable intermediate risk disease, we look at them as having shorter course hormones, typically no more than 6 months total. And the way that that's broken up is that the patient will be on hormone therapy alone for 2 months, about 2 months, and then we start radiation, and then we complete the radiation over what the term of the radiation would be, depending on the type we decide on. Patients who have high risk or very high risk tend to be on hormone therapy for a bit longer. So there are differences between European trials and United States trials, but essentially, I would say that a term of about 18 months total, between 18 months and sometimes 36 months, somewhere in that range, would be what patients in that category of high or very high risk would be on in terms of hormonal therapy. So it's hormone duration is predicated on risk, intermediate versus high versus very high. And we're also looking at trying to truncate that a bit. We know that the side effects of hormones can be pretty deleterious. You can have hot flashes, exercise intolerance, decreased stamina. There can be change in your cardiovascular profiles, things of that nature. So we want to be very judicious about how we use hormones. So we don't want to use them too long, but we certainly want to use them sufficiently to get the results that we want to get. So hopefully that answers that question.
I think
Yeah, I
so.
think part of the question was specific to how many doses they get, and it's whatever. There are so many different ways to give the same hormone, different brands. Some are 3 months, some are 1 month, some are 6 months. So I think that's the main difference is whatever combination of shots or now pills that you need to get you to your recommended 6 months versus 18 months versus 36 months. It's whatever the product that you are using that determines how many injections or pills, how long you take that.
Okay, that's good to know. Another question I have is which treatment option is best for me?
Is that a question from you?
No,
or-
that's just our next question.
Oh, that's
And
our
not
next
me
one.
specifically. I think
Well,
it's
Amy, you don't have a prostate.
exactly. So
Um,
I guess how do you determine what is the best treatment for
yeah, Luther alluded to this before. So this is all based on your age, number one. Everything is going to tilt the meter a little bit. Age, if you're younger, I'm thinking more surgery. If you're older, I'm thinking more radiation. Then, there's also biologic versus your biologic versus your numerical age. Plenty of patients out there are 75 running Ironman triathlons, things like that. Well, you're probably a candidate for surgery now, or versus 10 to 15 years, I would send you right over to Luther without considering it. And then you also unfortunately have very unhealthy 50-year-olds. So if you have other competing medical risks, so heart attack, things like that, well, prostate cancer certainly can't be ignored. Those things tend to be more of we got to take care of that first, with prostate kind of in the background, and maybe we don't want to be as invasive on those patients. So it's overall health, your overall age, and personal preference. Again, it depends on what is the grade of the cancer? How aggressive is it? Where do we put you in that low to intermediate to high risk profile? Are you going to need hormones if you have radiation? How long are you going to need them? If you don't mind, then fine. Do you have good erectile function now or not? If you don't, then you might not care about sexual side effects that both of them have. So these are, all of those come into effect. I personally give everyone a recommendation to see radiation oncology, usually regardless of age. Sometimes the younger guys be like, just take it out. I don't need to do that. That's fine. But it's best to see both, someone, a urologist as well as an oncologist, a radiation oncologist, to go over those with you, because they're both good options.
Okay.
Yeah. So as Dr. Kowalczyk said, it's a fairly complex conversation. And so when I speak with patients, I try to work them through all the variables that Dr. Kowalczyk talked about. And I too recommend that they see a surgeon to kind of get all the input. There are going to be some patients that are disinclined to have surgery. I don't want to be cut. There's some patients who want it out, as Dr. Kowalczyk said. So personal preference does weigh a lot in it. And I know that a lot of times, and Keith probably gets this as well, patients will ask me what I would do for a family member. But it really comes down to our providing you the information about, number one, what's efficacious, what's effective for you. Number two, going through what the side effect profile will be. So side effects of surgery may be different from radiation. Even within radiation, there may be different side effects that occur at different times, more acute, meaning sooner versus later. And so I'll walk patients and their family members through that. And then depending on their personality, their lifestyle, all of those things come into play in terms of what they actually want to choose. So that's the conversation that we have. It's definitely a conversation where the patient participates significantly. The significant other participates as well. And so it's shared decision making when we come to what would be the best option for a particular patient.
Yeah, and it's a long but good and detailed conversation that you have to have, because the last thing I want is anyone going into treatment not being sure that that's what they want. And usually, if we do our job well, at the end of that visit, the patient kind of has an idea of what they want to do, and I support that. There'll be a few cases where I'm like, I will push really hard for surgery, or I'll push really hard for radiation. That does happen. But it's a long discussion, and we're here to kind of help you decide what's important for you, what's not, answer any questions, and go through some of the myths that we'll go over later. what are facts versus myths.
And what are potential side effects for some of the treatments that you mentioned, and do they affect quality of life?
Well, from a radiation standpoint, side effects, I generally break them down into plumbing. The first thing I do is I show the anatomy. So I make sure the patients understand where the prostate is in relationship to the bladder and the rectum, and also understand that the urethra goes right through the middle of the prostate. So once they have that picture, now they can kind of understand, okay, radiation, especially with the technology and the planning that we have nowadays, is very focused. So it's not going to involve the intestines. It's not going to be deep into the rectum. And there are also things that we can now do as well by putting a gel between the interface of the prostate and the rectum to move the rectum out of the way. So when you look at that picture, knowing where the bladder is, where the rectum is, it essentially comes down to plumbing. So how active is your urinary plumbing going to be? So when we give radiation, we will have these sort of irritative urinary symptomatology. You might go to the bathroom more often during the day. You might get up a little bit more at night. The interesting thing is that some patients have burning, but burning is not as predominant as you might imagine, because patients have this idea that radiation is burning the tissue, but it really is not as significant as one would believe, especially when we do it with the very focused treatments we have nowadays. But you might have the sensation that you haven't completely emptied. So you go to the bathroom and then you kind of walk down the hall, then you got to turn around and kind of go back and empty some more. You might have hesitancy, which means that rather than having a 5 count in your urine stream start, it might be a 10 or 15 count before you start. And I would also sort of make a difference that usually when you get up, the first time you get up in the morning, it's normally going to be slower than the rest of the day anyway, because, you know, when we sleep, the brain has what's called an autonomic function, which kind of tightens that sphincter down a lot more so you don't pee on yourself overnight. So that's why nighttime urination tends to be slower than daytime anyway, but certainly radiation can exacerbate that. In terms of rectal side effect, we're really kind of eliminating that nowadays, because even when we were using IMRT, which is intensity modulated radiation therapy, and we could shape the radiation very well, we were limiting the amount of rectum. But now that we can put a gel between the rectum and the bladder, and the prostate, we can really move the rectum out of the way, and we don't have much rectal toxicity. But if you do, you have some irritative stuff. You might have softening of your stools. You might feel like you're producing a little bit more mucus. The long-term consequences of radiation are mitigated a lot more nowadays as well. So we tend not to have as much rectal bleeding. That's very, very low. You may have some stricture or narrowing of the urethra. That might be a potential complication down the road, but again, that's low. For the most part, the side effects that patients get from radiation are acute. They happen during the time that we treat or for a few weeks afterward, and then they remit. And then patients usually have really good urinary function after that. The one thing that radiation is unlikely to cause is incontinence. So that's almost never heard of. So so that's something that we really don't cause. But of course, as Dr. Kowalczyk has alluded to already, impotence is a treatment that is a symptom or a side effect of radiation that can happen. And it depends on function prior to radiation, whether or not we use hormones. So it can be very multifactorial, and we have that discussion with patients as well.
Okay. What are the
Yeah.
chances? Oh, sorry. Are you
Well, for
done?
surgery, do you want me to go over
Oh,
surgery?
sorry.
We can't leave out surgery now.
Yeah, it's a big one. So for surgery, again, we used to have a long talk about blood transfusion, infection, things like that. That's like, sure, you're having a surgery and these things can happen, but that's more in the order of less than 1% versus when we were doing this open and I was a resident, it was a 20% chance we give a blood transfusion. Now it's almost never. And that's because of robotics. So, and patients now go home the same day. So while it is still a surgery, there are those inherent risks, just as there would be any other surgery. The actual surgery itself tends to be much less morbid than it used to be. Now, you have to take it easy for about a month, but you get back to your normal activities very quickly. One good thing about surgery is the prostate's gone. So if you have trouble urinating already and it's a big prostate, we get rid of that, and we don't have to have those problems starting and stopping and things like that. So that's one benefit. If someone has a very large prostate or has had prostatitis with prostate pain and things like that, which is a multifactorial thing, it's not going to cure it, but surgery might be a little bit more beneficial. The downstream effects are urinary incontinence and impotence or erectile dysfunction. Thankfully, we have been able to limit, just like the radiation oncologists and Luther have been able to limit rectal side effects with the rectal spacers. That's been a game changer. For surgery, we're starting to approach with what's called a pelvic fascial sparing approach, which we here at Georgetown, I'm proud to say, really spearheaded here in the United States, originally started in Italy, where we're able to preserve a lot of these attachments to the bladder and urethra, where we frequently would have to just remove all of those. And that has hastened recovery. So patients are getting their continence back much faster. Within 6 weeks or so, 80% of my patients are happy and pretty dry. Very rare do they have severe incontinence. And in my experience, 95% of patients at a year have no issues with incontinence. So that's been a development that's been really nice over the last few years. Erectile dysfunction, though, is still going to be something that's difficult to maintain. So the erectile nerves, and again, like Luther, I show the anatomy so people can understand this is why these side effects happen. It's not just a nerve to stay away from. These nerves are physically attached to the prostate. So even if we do what's called nerve sparing, I have to physically detach those nerves from the prostate, and just doing that little bit will cause what we call, neuropraxia. So if you get a funny bone and you're numb for a little while, if you wake up with a numb leg or arm, that's neuropraxia, and that can happen to these nerves. And generally in younger patients, especially if they have good function beforehand, if the nerves are good in the beginning, and that tends to be young patients, they'll probably recover much quickly, usually within 3 to 6 months. If it's someone who's older and already has some baseline dysfunction, it's going to take a while if ever it comes back. I quote about 50-50 for all comers. If you're younger and I can spare your nerves on both sides, then it's up to 80% probably. But my ability to spare nerves is also depending on how bad is your cancer. Because if your cancer is right on one of those nerves and I'm cutting into the nerve and into the prostate to spare it, I'm going to leave cancer behind. So we can't do that all the time.
Right.
So, and that's again, that's what we go over in the pre-op is, here's your tumor, it's near the nerve bundle. How is your baseline function now? Okay, I'm realistic. I'm not going to tell everyone they're going to come out of this scot-free, but erectile function is probably the biggest thing. But the same happens with the radiation, especially if you need one.
Thank you. Let's jump into our common myths about prostate cancer treatment. First one being, if there are no symptoms, I can't have prostate cancer.
Yeah, that's a big false. The majority of almost all prostate cancers are asymptomatic. The symptoms that you feel, going to the bathroom, having trouble going to the bathroom, that's enlargement of the prostate, which is actually benign enlargement. That's not cancer causing that. So it's a good thing that you don't feel anything. We don't want that. If you do have symptoms from prostate cancer, it would usually be because it's metastatic or stage 4, and you're feeling pain from where the cancer is spread, whether it be in your lower back. Some people get big lymph nodes and get leg swelling. Thankfully, because of screening, we do not see that as much anymore. That used to be how people presented. So again, screening has saved lives. Screening has made this an asymptomatic cancer, which is, two sides of one coin. It's fantastic, but there's really nothing to look out for other than talk to your doctor if it's appropriate to get screened.
And not having symptoms is really important, because with screening, we want to be able to find cancer when it's early and treatable and curable. And so a lot of patients will come in and say, well, I didn't feel anything, or I feel fine. And we're saying, exactly, that's the reason that we're screening, because going back to one of the original comments I made was that prostate cancer is prevalent. And so it's one of those things that can grow very silently. And if it's very small and non-aggressive, or even it might be a little bit more aggressive, we still have an opportunity to get it when it's localized and contained. So as Keith said, most patients, vast majority, almost all, don't have symptoms related to their cancer.
Our next myth, you don't have to worry about prostate cancer if you don't have a family history.
I think Dr. Kowalczyk touched on that earlier. Family history makes you more likely to get it, but certainly it's a disease of men, and it's a disease of men as they age. So if you actually look at cohorts of men that are, say, 80 years old, 90 years old, if we go looking for prostate cancer or evidence of it, we're probably going to be in the 80s to 90% range, right in that range. So ultimately, men will have evidence of prostate cancer. Now, whether or not it becomes clinically significant, meaning do we need to do anything about that, that's a separate discussion point. And so that comes back to Dr. Kowalczyk alluded to active surveillance. So there are some patients that actually don't need to be treated, But certainly, just because you don't have a family history does not mean that you don't have the risk. It's 1 in 8 lifetime, and we talked about the percentages earlier in this conversation.
Wow. Next myth, screening tests do not help, which we've talked a lot about screening tests.
Yeah, but I think it's worth mentioning that's absolutely not true. There's screening tests aren't perfect. I will say that all of the time. What doesn't help is having a knee-jerk reaction to every PSA that you have, biopsying everybody no matter what, and then treating everybody no matter what. That's the problem with PSA screening, is the doctor's reaction to it. But screening tests themselves have dramatically decreased the number of prostate cancer deaths and how many people present with advanced stage cancers. It's up to us to use that information better, not have if you get a single PSA and your urologist is like, we got a biopsy now. It depends on what it is. If it's really high, look, I know there's certain situations, but we as physicians needed to do a better job of not over treating patients that don't need treatment with low risk prostate cancer. And I think we are doing that. But without screening tests, we'd be missing a whole lot of high risk prostate cancer patients that Luther and I still see every day. So, another myth is I won't die from prostate cancer. That has been going around since, people were saying don't get screened, and it's just not true. It's still the second leading cancer cause of death in men. So it's just not true. But if we get it early, certainly we can help.
I think just to emphasize what Dr. Kowalczyk said, it's really about how physicians look at elevations in PSA and positive biopsies. I mean, not everyone, we talk about the overdiagnosis. I think that's been the controversy about PSA. We don't want to overdiagnose, but just because we have the information doesn't mean that we have to do something invasive or we have to throw the kitchen sink at it. We can have the conversations that we've talked about, and we might decide that, hey, let's actively surveil this, let's watch it, not do anything, and kick the can down the road. We might ultimately treat, we might not treat. I mean, I'm sure Dr. Kowalczyk has patients that he's been watching for a number of years. I have a series of patients who are probably out 10 years or more now that we've been just watching PSA. We biopsied them a couple of times, nothing advanced, and they're on their way without treatment. There's some men that we get the screening in, we don't do anything right away, but we might jump in 2, 3, 4 years later. So it's really, I would definitely agree with Dr. Kowalczyk. It's about how the physicians handle the information, communicate the information, and what decisions we make with the patients as a team.
Okay, our next myth, a high PSA score means you have prostate cancer.
Not necessarily. I will say that most prostate cancers do have high PSAs, but not all. Certainly if your PSA is in the 10 to 20 and above region, and unfortunately sometimes we see men that haven't been screened at all and come in the hundreds or thousands. Those ones mean you have prostate cancer. But if it's less than 10 and just elevated, it does not mean you have a prostate cancer at all, because PSA is prostate specific. It's not prostate cancer specific. So if you have a bigger prostate than most people, you have more prostate cells, all of which are making PSA. And PSA is a normal protein made by the prostate to do its job. So it does not always mean you have prostate cancer, which is why we have the secondary PSE and tests like that. That's what we do when patients have elevated PSAs, MRI, other blood tests. We have other ways to kind of see, is this something that's due to prostate cancer, or one of those very common things like infection or large prostate that could cause an elevated PSA.
Another myth, only elderly men get prostate cancer.
That would be false. It is a disease of older men. Again, the average age of diagnosis being about 65 to 67 or so. But earlier I talked about even in the decades under 50 years old, we can get diagnoses, especially in certain high-risk populations, which is why we talk about baseline screening. And certainly that the likelihood of getting disease increases if we go looking for it as men get older. But it certainly can happen in men who are in their 50s to 59, 40 to 49, but it's significantly rare below that for sure.
Next myth, prostate cancer surgery will end your sex life and cause urine leakage.
Yeah, so I think I mentioned this before. Certainly it will impact your sex life. I think that will happen to anybody. In younger patients where we're able to spare the nerves, it will do it less so. But I think, it would be naive of me to say it wouldn't have any change whatsoever. I things may change, and that's something that we prepare couples for. And hopefully, we have treatments that can make that better. But it should not end your sex life whatsoever. And it's a discussion, we would have beforehand. What are the odds that we can get you back to good functioning? We have a lot of lucky patients that get back to 100%. Again, I think that's lucky and optimistic. I think realistically, we can get younger patients with nerve sparing, 80% of them in my hands back to good functioning where they'd be happy with. As far as urine leakage, we're much better at that. It will be, you can of course get it, and usually it's not severe, and in most men it goes away. In my hands, 6 months. We do not thankfully have patients that just leak at all times, that need a clamp to keep their urine in, things like that. Thankfully, that's largely been left in the past because we've gotten much better at the surgery. So both of these things are affected 100%, but we've also gotten much better at preserving them. So we can cure the cancer, but also hopefully maintain quality of life.
And next myth, prostate cancer is always fatal or never fatal.
So if we look at the prevalence, we talk about, let's say, use the numbers for 2024. We're expecting about 300,000 diagnoses, and certainly we've had those diagnoses prior. We've had at least, let's say, 250,000 over the last 5 years per year. When you look at the number of deaths, we're talking about 35,000 or so, 30 to 35,000 per year, which is about 6% of the overall total. So there are patients who die of disease. But for the most part, it's a disease where patients live longer lives very well, actually. And so it's not always fatal, but it can definitely be fatal.
Yeah. We should never get into extremes about any of these things. And, but I've heard patients say both of these things, which is why I think it is there, is it certainly can be fatal. But, it's somewhere in between, like any other cancer.
And our final myth, you have to start treatment right away.
This is one of the luxuries we have with prostate cancer, is that we definitely don't want to defer treatment to a point where it's deleterious to you or your outcomes. But we have lots of data showing that from the date of diagnosis, and we know the cancer's been going on since diagnosis, but all we can say is the date of diagnosis up to 6 months after treatment. Obviously, the cancer is not going away in that amount of time, but there's no difference in the ultimate outcome of being cured from cancer. I tell her, I don't want to wait 6 months. I know you want to get this done. But we also want to do the right thing. I want to talk to you. Luther needs to talk to you. You might need physical therapy. We might want to get other staging tests. Like if you have a high risk cancer, we'd probably want to get a PET scan and things like that. If you've had a biopsy, we want you to heal from the biopsy. It's now June. If I diagnose someone now, I'm sure they have a family vacation planned. I don't want them to cancel that either. So generally I say I would like to get this treated within 3 months. We can probably safely go up to 6 months. This is for intermediate to high risk. So we're talking about patients that need treatment. If it's active surveillance, obviously we're not actively treating that at all. But we have the benefit of time. And I don't want anyone to go away thinking I don't need to treat it at all. But we have the benefit of time, and we'd like to use it to make sure that we get all the tests we need. You get all of your vacations in there and don't cancel life for this, and you make the right decision. You go into your treatment knowing that you're ready and you're doing the right thing.
Great. Well, that's all the time we have today. There were some more audience questions that we didn't have time to get to, but we will get to those offline. And any final thoughts, Dr. Kowalczyk or Dr. Ampey, before we wrap up?
I think prostate cancer is a disease that has a high prevalence, which means we cannot ignore it. Therefore, I would emphasize that screening is important, understanding what your risk factors are, and understand that treatment does not mean that you have to have a significant change in your quality of life. There can be some changes, but the earlier we find it, the more options you have and the better off you'll be ultimately.
Yeah. I think number one is getting the right message back on track, which is that screening has saved lives. Smarter screening has also avoided overtreatment. So we're at a point where you definitely should get screened, and if there's any concern, see a urologist, radiation oncologist, or talk to your primary care, but don't ignore it, because it doesn't mean that we're taking surgery or radiation. Might not do anything, but we don't know what we don't know. The other thing I want to say, and I'm sure there's patients on this because they've been recently diagnosed. People come out of the woodwork because it's so prevalent that you're all of a sudden going to see this patient, your friend had this done, your other friend had this done, your other friend had this done. They're doing terrible. They're doing great. As we kind of alluded to, everyone has a different story that's based on so many different things. And that's the reason why they get those treatments. They may do better, they may do worse. You are an individual person, and your treatment should be based on you and not what you've heard, your cousin Joe had versus, Uncle Greg. So that's another thing I want to say is take all of those stories in. It's very worthwhile, so you know what you're getting yourself into. But at the same time, that might not be your story. Come to us, we'll get you the right treatment for you.
That's great. Thank you so much to Dr. Kowalczyk and Dr. Ampey for taking the time to join us today. And thank you to our viewers for tuning in. For more information about prostate cancer treatments or to schedule an appointment, call 888-666-3432 or visit the link in the comments, and we'll add the phone number in the comments as well. Thank you so much, and we'll see you next time.
Thank you.
Thank you.